right.
What are the levels of vaginismus? There are more severe types, and there's also other things that cause sexual pain that can be treated in other ways. I'd like to get that cleared up.
I think one has to look at painful intercourse as kind of a very broad spectrum. So you can start with the least involved patient where they may have an associated skin condition, or they may be perimenopausal or menopausal where they have some dryness, and they may have some discomfort with intercourse. And the name for the discomfort is dyspareunia, and dyspareunia is basically painful intercourse.
So any form of painful intercourse is dyspareunia?
Any form of painful intercourse is dyspareunia regardless of the cause.
Mm-hmm.
And we see this a lot also with perimenopausal and menopausal women. And then the spectrum continues through that to moderate discomfort with intercourse. There could be discomfort with intercourse. There could be discomfort after the intercourse. There can be burning after the intercourse. Then you get into the more severe forms of dyspareunia. We're still at painful intercourse, but we're kind of advancing up that spectrum. And these people are having a lot of pain with intercourse. They might have hours of burning after intercourse, very uncomfortable, and oftentimes the cause is unknown. Sometimes I think that the associated skin conditions that could take place are sort of a red herring, and I really think that it's not so much the skin condition causing it, it just happens to be an associated medical problem. So there's a fine line between severe painful intercourse and vaginismus, because in vaginismus you just can't have intercourse, or it could be extremely painful where the woman just avoids it.
Right, I've had a couple of clients that say that they get very, very drunk. They force themselves through it so that they can get pregnant and have a child. But then other than that, they avoid it completely.
They overdose on antidepressants. They overdose on alcohol. They go unconscious, and I've had patients like that too. So now we're kind of at the beginning of the vaginismus, at the beginning of that spectrum, and so we then now fall into this so-called Lamont classification. Lamont is a gynecologist who classified vaginismus according to 4 levels of severity. The diagnosis is made on the history, but also on physical examination. So when the patient comes in for an examination, you can determine the level of vaginismus on the basis of how they react to the physical examination. So a person with a level 1 vaginismus will be able to relax through the examination. In a level 2, the patient's tight and unable to relax. In a level 3, the patient starts elevating the buttocks and closing the thighs. That's that avoidance situation. And in a level 4, the patient elevates the buttocks, retracts away from the table, clamps her thighs shut, and will not allow an examination. I have patients who said, there's a level 5. I've had patients tell me, they're a level 5 because they are in a profuse sweat, they have nausea, they have vomiting, they're ready to run away, they're ready to jump off the table. And so we are actually, I'm incorporating now an expanded Lamont classification in my own way of thinking about vaginismus patients, so we have a level 5. The lower levels, levels 1 and 2, you can sort of work with those patients. But a level 3, 4, you can do all the counseling in the world, you can do all the hypnotherapy and psychotherapy and physical therapy. They're just not going to be they can order dilators, they won't even open the box of dilators.
They're scared of the dilators,
So the level 4, the level 3s and the level 4s are very, very serious. And those are a lot of the patients that I see because they have failed conservative therapy.
What is different when they come to you? why will a woman who's been so scared, why can she get through this? Is it scary for her? Is it painful for her? What is the process?
Well, for one thing, they know we're going to do her under anesthesia. Mm-hmm. And that is immediately a very humane way of working with people. Because if somebody's going to be that terrified, put them to sleep.
Right.
So I have a certified surgery center in my office, which I've had for a long time. And this doesn't respond to local anesthesia because you can't approach a vaginismus patient with a needle that's going to go any place near the vagina.
Right, right.
So that's not going to work. So we put them to sleep.
Right.
And they know that. And so nowadays, not only do they know that they're going to have the Botox, but I also inject a long-acting local anesthetic because we dilate them right at the time of the procedure. Mm-hmm. So we progressively dilate them from smaller to large dilators. We usually leave in a number 4 or a number 5 out of 6 dilator, which is a pretty big dilator.
So that's inserted while they're asleep?
Yes, it's done at the end of the procedure. And then we coat that with some topical anesthesia. I inject into a variety of places with a long-acting local anesthetic. So when they wake up in the recovery room, they don't feel the dilator because we've got topical anesthesia, we've got local anesthesia, but they know the dilator's in because I told them the dilator would be in. And so I love this moment because just as they're waking up and they're kind of awake enough to talk to me, I just look at them and it's just kind of fun because they're looking at me like, I know there's a dilator in there, but I don't feel it.
Right, and I feel no pain.
And it's just really such a I really try to be present during that monumental breakthrough because it just is really a lot of fun because for a lot of patients it's the very first time they've ever had any penetration. So in the recovery room we start working with the dilators, and the first thing that they do is they just feel the dilator, that it's there. So they take their fingers and they feel the disc of the outside of the dilator, and that's in there. And then over the next hour, my recovery room nurse and my staff and I will work with them, and they start just turning the dilator clockwise and counterclockwise, and then they'll move it out an inch and move it in an inch, and all of a sudden they're doing something that they never thought was possible. Mm-hmm. They just never in their wildest dreams could imagine that. And then the next monumental thing that happens is when they see the size of the dilator. And they say, whoa, this is big. And I say, yeah, and it doesn't hurt you, right? I mean, because we have to get the patients just over it's just like a wall. You got to get them past that. Mm-hmm. So in the recovery room, what will happen is, once they get comfortable with the idea of turning it counterclockwise, clockwise, they move it in, they move it out, then they actually take the dilator out completely, and they reinsert the dilator completely themselves. Yeah. And again, this is another monumental step. I mean, we are dealing with a whole series of monumental steps in the first 3 hours after they wake up.
And many times you have the husband or the partner in with them.
Absolutely, and it's extremely valuable to have the husband in the operating room with me, because I very often have them put on a pair of gloves. They can feel the spasm, and there is terrific bonding that takes place when the husband or the boyfriend is there seeing what their loved one is going through and understanding for the first time what their loved one is going through, because they don't understand it. The woman doesn't understand it, and the mate understands it even less. And then when they go home, they maintain, or they go back to the hotel, because I have a lot of out-of-town patients, and they maintain that dilator for 36 hours. And then we counsel them some more in the morning. And during this period of time, because we usually like our patients to be with us for about 3 days, because it allows us to really get into the groove of the dilation, we can really counsel them and instruct them. And then I start also speaking to them about the transition, because the transition from dilators to intercourse is another monumental event.